Today we are going to talk about the thyroid gland and the 6 patterns of hypothyroidism. In our office, we see a lot of patients with thyroid dysfunction. We always ask the 3 basic questions. When did you first notice you had symptoms? How long did it take to get diagnosed? And how often do you change your dose? Most of our patients have tried everything to get their energy back and to feel good again. Thyroid problems are often not diagnosed for 2 reasons. First, doctors do not run enough lab markers. Secondly, the lab ranges are too wide. We utilize functional ranges, and our TSH is 1.8 to 3.0. The current medical model, which is a 50-year-old model, falls short in fully identifying the cause of the thyroid condition. It is based upon a limited number of lab markers focusing on TSH and T4. How can you manage the thyroid without all the information? As you will see in the next few minutes, there are several other lab markers that need to be addressed to determine the actual cause of the thyroid problem. Our complete thyroid panel includes TSH, T4, free thyroxine index, free T4, free T3, T3 uptake, reverse T3, the TPO and TBG antibodies, TSH antibodies, and TBG levels. When necessary, we will also run other labs to determine the cause. Proper testing is crucial. A complete metabolic panel, including all the thyroid tests described above, we want to look at liver function, anemia, blood glucose levels, hormone tests, salivary cortisol levels, Cyrex testing for gut permeability issues, stool testing looking for infections, yeast, or parasites. We also at times will run an organic acids test. Other tests we may recommend is genetic testing and the MTHFR gene, hair analysis to evaluate copper and mercury toxicity and deficiency of essential nutrients. For the thyroid, it is extremely important to know how the thyroid works. Then, when we discuss the 6 patterns of hypothyroidism, it will become clear where the problem arises. First, the symptoms of a thyroid dysfunction are fatigue, depression, weight gain, hair loss, constipation, morning headaches, muscle cramps at rest, dry or brittle hair, chronic digestive issues, and loss of the outside portion of the eyebrows. The thyroid supports bone metabolism, the immune system, the brain and nervous system, the endocrine system, GI function, liver and gallbladder, growth and sex hormones, fat burning, healthy cholesterol levels, and a proper stomach acid. Every cell in your body has a thyroid receptor. The receptor is located in the DNA of every cell. The job of the DNA is to make protein for the survival of every cell. It is dependent on vitamin A and methyl groups. There is also a crosstalk with the thyroid and the immune system, the thyroid in the gut, the thyroid in the brain, and the thyroid in the endocrine system. One affects the other. This is an overview of the thyroid gland and how it is converted. It all begins in the brain. The hypothalamus releases a hormone, TRH, to the pituitary gland. The pituitary gland then signals the release of TSH, which is what is usually tested on lab work. The pituitary gland also regulates the release of other hormones, ACTH to the adrenal glands. You can see the adrenal glands are responsible for the release of cortisol, progesterone, aldosterone, DHEA, epinephrine, and norepinephrine. The pituitary gland also releases luteinizing hormone and follicle-stimulating hormone to the ovaries and testes, which helps control the menstrual cycle and testosterone. To make thyroid hormone, the thyroid gland needs iodine and tyrosine. T4 is 4 molecules of iodine and 1 of tyrosine, and T3 is 3 molecules of iodine and 1 of tyrosine. The thyroid produces 93% T4 and 7% T3. To transport the molecules, they hop on a protein or a taxicab which is called TBG or thyroid binding globulin. This taxicab transports it to the liver where T4 is converted to T3, the usable form of the thyroid hormone. 60% of T4 is converted to T3 in the liver. Selenium is extremely important in the conversion of T4 to T3. 20% is converted in the gut and 20% in the other peripheral tissues. As you can see, it is essential to have not only a healthy liver, gut, pituitary, adrenals, but we also need iron, iodine, selenium, zinc, magnesium, and tyrosine to make it all happen. Once again, they bind to a protein, TBG, to carry it to the cells. Free T3 is the active form of the thyroid hormone. To repeat, every single cell in the body has a receptor site, and this cell is dependent on methyl groups, vitamin A, and iron for absorption. The 6 major thyroid patterns. The first pattern is primary hypothyroidism. This is when the lab shows a high TSH. So if the pituitary gland senses the thyroid isn't doing its job, it will pump out extra TSH, giving the thyroid a kick in the pants. Primary hypothyroidism is a true dysfunction of the thyroid gland as the only pattern of hypothyroidism that can be effectively managed with thyroid replacement hormone. Sometimes Hashimoto's can benefit from the supplementation of a hormone replacement. As you can see, the lab range of TSH is 5 to 4.5. Anything above a 4.5 is considered primary hypothyroidism. The functional range is 1.8 to 3.0. The second pattern is hypothyroidism secondary to pituitary hypofunction. On labs, this will show a low T3 and high cortisol. So the TSH is usually below 1.8 and the T4 below 6. This is a very common pattern of functional hypothyroidism. Here, the TSH will be below 1.8, although not as low with a primary hypothyroidism, but you will still have symptoms. Chronic stressors are at the root of this pattern because they fatigue the pituitary gland at the base of the brain. Then the pituitary fails to signal the thyroid to release enough TSH to stimulate activity. In other words, the thyroid gland may be perfectly fine, but nobody is telling it to go to work because the pituitary is asleep on the job. Pituitary hypofunction is usually the result of one of 4 things. An active stress response, which could be poor diet, inadequate sleep, too much caffeine, or high carbs. Chronic inflammation, which can be viral or bacterial infections, where the body just gets worn out. Postpartum depression is another cause. And then fluctuating insulin glucose levels is the other cause of the pituitary hypofunction. In this situation, as I said, the TSH is less than 1.8 and the T4 is less than 6.0. The third pattern is thyroid underconversion. This is when there is low T3 and there's difficulty in the conversion from T4 to the active T3. So this is a common pattern associated with chronic stress and excess production of the adrenal hormone cortisol. Here the body makes plenty of T4, but too much cortisol prevents the body from being able to convert enough T4 to T3. The form of the thyroid hormone the body can use. An elevated cortisol level suppresses the conversion of T4 to the usable form of T3. Another common cause is deterioration of the body's cell membranes in response to chronic infection or inflammation. Cell membranes are in charge of multiple functions, including the conversion of T4 to T3. Chronic inflammation causes lipid peroxidation in which harmful radicals damage the cell walls. and damaged cell walls hamper thyroid conversion. Finding the cause of the inflammation are the key to support. So this is when the TSH is normal, the T4 is normal, and the T3 is less than the functional range of 100. The fourth pattern is thyroid overconversion. This is when we have a high free T3 and a high reverse T3 is our lab marker. This pattern is found with insulin resistance and polycystic ovary syndrome. Since excess testosterone production accompanies these conditions, reversing insulin resistance reverses hypothyroid symptoms. This pattern also arises in those who have already developed diabetes and are taking insulin. Gaining control over blood sugar and insulin needs with diet, supplementation, and exercise are critical. So here we have a high free T3 and a high reverse T3. The fifth pattern is thyroid binding globulin elevation. Here's where low T3 uptake is low and the free thyroxine index is low and or normal. There's too much TBG in the blood and there's too little free T3. This pattern is often found with oral contraceptives or estrogen replacement therapy. Thyroid hormones hitch a ride through the bloodstream on thyroid-binding globulins. Since thyroid hormones in the blood bind to excess TBGs, not enough free hormone is available to enter the cells. Clearing the body of excess estrogen addresses hypothyroidism. So on labs, this will be free T3 will be low and the T3 uptake will be low. The sixth pattern is thyroid resistance. This is when the thyroid panel is within normal limits, but there can be elevated or there will be elevated cortisol levels. This is another stress-related pattern in which the pituitary and thyroid glands function normally and make the right amount of hormones, but the hormones are not getting into the cells to take effect. Symptoms of hypothyroidism show up elevated. We'll have elevated levels of cortisol in response to stress, causing the cells to become resistant to thyroid hormones. Other causes include high homocysteine and a genetic predisposition to hypothyroidism, such as the gene FOXV and FOXC1 gene becomes expressed. Based upon our functional medicine lab findings, we will support the thyroid, the adrenals, the liver, the gut, blood sugar levels, anemia, and regulate the autoimmune system. We must address the nutrient deficiencies, food sensitivities, adrenal dysfunction, gut dysbiosis, and liver detoxification issues. I completely understand how you feel if you are frustrated and have no energy. A lot of our patients with thyroid issues felt the same way. Proper testing is essential to finding the cause. Thank you for listening. If you have any questions, email me at dr.veselak@gmail.com. You can visit our website at drmichaelveselak.com, and our Facebook page is Camarillo Functional Health.